the Voicing Collegiate Recovery Program. The format of our session is that our main speaker, Kate, will be followed by two UCR medical students who recently completed externships at Rebecca Clinic. And then comments or questions will come from our three-person panel. If you have questions during the presentations, please put them in the chat and I will ask them as time permits. If you continue to have questions after the session concludes, we'll try send them to Francis Fernandes at ucr.edu. Please see how my name is spelled. And I will forward them to the presenters. So our main presenter today is Kate Roselle. Kate Roselle works for Hazelden Betty Ford. The Betty Ford of it, of course, is a neighbor of ours out in Rancho Mirage. And she is the National Youth Outreach person. And so she deals with all kinds of youth programs. And she's going to talk to us today a little bit about the role of neurology, the neurology of addiction and the part it plays in treating college age, and a couple of other things. So let me give the floor to Kate, because I'm looking forward to hearing her.
Thank you, Francis. Hello. As Francis said, my name is Kate Roselle. I'm the National Youth Outreach Manager for Hazelden Betty Ford. I've been with Hazelden for about 9 years. I started at Hazelden as an intern when I was completing my psychology master's. So I have a master's in adolescent psychology, a license in clinical counseling, and a master's degree in business administration and leadership. So I worked in the clinical side for Hazelden for many years, and then just in the last couple of years transitioned to the business development side and to outreach. And so that allows me to do a lot of presentations like this, and I just love doing it. It's weird now in this virtual world because I want to be able to see you and connect with you and hear your questions and shake your hands, but here we are. So I've got just a few minutes. I want to talk about some of the things that face us when we are treating college age patients. And so there are kind of three pieces that I'll talk about. The first piece is that brain development, kind of developmental era that the college student is in. And the second piece is how our current virtual world is impacting chemical use and mental health. And then the third piece is how we're treating people virtually, and what the successes of that are looking like. Also, if you hear sounds in the background, my dogs are trying to break into this room. So if it sounds like somebody's trying to break in, it's just the dogs. Don't worry. So the first piece of this is brain development. So when we are working with these young people, kind of in that 18 to 21 range, one of the biggest things we face is that what's going on with their brain development is that their logic and reasoning center is not developed. So the developing brain is not finished until about the age of 25. So when we're working with these kiddos fresh out of high school, coming into college, what's happening with their brain development at that stage is their reward center is developing at that point. So I want to do the thing that feels good. I want to do it right now. Impulse control issues, just constantly seeking that reward center fulfillment. And the piece of their brain that has only just started to think about developing is their prefrontal cortex, which is the logic and reasoning center. So when we think about then what that means when we're working with these young folks who are struggling with chemical health and mental health, that's certainly a barrier that we have to consider is, okay, what's the developmental appropriateness of some of the interventions I'm using here? And so thinking through, okay, if their brain feels good and do it right now, and the part of their brain that's not working yet is, wait, is that a good idea? Let's think about this, weigh some pros and cons, think about future me. What would future me prefer I do right now? And that part's not working super well yet. So we got to think about that when we're working with these young folks. And a part of that developmental process too means that identifying the signs and symptoms of a substance use disorder is a little bit trickier, because some of the signs and symptoms of substance use disorder are things like weird sleeping patterns, up all night, sleeping during the day, changes in hygiene, changes in friend group, changes in classroom performance. And a lot of these things you're seeing naturally anyway as kids are transitioning into college. Change in friend group, they're up all night studying, sleeping all day. Maybe they're stressed out, so they aren't bathing as much as they used to. So a lot of these signs and symptoms are actually normal things that we're seeing too. So when I work with professionals who are working with these young folks, one of the things I recommend the strongest is what we really want to look for is the additives of all of these things. So it maybe is not one thing, maybe is not a second thing, but when we start to see multiple things, we might, maybe now at this point we're seeing a pattern as opposed to, okay, their sleep pattern is different, they happen to be in college. But maybe if the sleep pattern is different and the friend group also changed and their grades are changing and all of these things are kind of happening, then we have a chance to take a look at it. And oftentimes, faculty and administration are some of the first people seeing these signs because families are often not there. They're far away. So as we're working with these young folks, it's really looking at the patterns and understanding what's happening in the brain at this point. And once we're seeing signs and symptoms and we have questions, it's time to act. And I get that a lot from families is, I know that something's not right, but I'm going to continue looking for evidence that something's not right. And so once we know that something's not right, we got to do something about it. So right now in our world, we have this whole virtual contribution to what's going on. And one of the huge contributing factors to an onset of a substance use disorder is feelings of isolation and mental health, depression and anxiety. And so at Hazelden, we're dual diagnosis. So we treat both mental health and chemical health at the same time because you have to, because they're so enmeshed and just grossly intertwined. You just have to. And so what we're seeing in this virtual world is more isolation and higher rates of depression and anxiety. And so then, of course, since mental health and chemical health are so intertwined, when we're seeing upticks in things like depression and anxiety, that means we're also seeing upticks in things like substance abuse. So the virtual reality that we have right now is not doing great things for substance use disorders. I was on our national sales meeting this week for Hazelden Betty Ford, and one of the things we talked about is that online alcohol sales are up 339% since the pandemic hit. So I'm a numbers person, right? 339 is a big number, even if you aren't a numbers person. So this is very sad, and it means that we need to be paying closer attention and stepping up in a bigger and more fulfilling way. And so one of the things that we've done at Hazelden Betty Ford is we have developed our Recovery Go services, which is our virtual treatment services. We actually started working on this about a year before the pandemic hit, which was really great because we had the platform up and ready to go. We had licensing ready to go. We had everything ready to go. We just had to launch it 3 months earlier than we planned. So we felt very, very fortunate to be able to step immediately out into the community and say, we've got you covered. We can help you with this. And so I think when virtual services first got started, and when we first started heading out into the market and calling providers and saying we can help here, we can step in and help here. We're of course still running our full residential services in person, but we can step in and help here in a big way. There was initially some skepticism around, okay, well, how effective is a virtual outpatient group versus an in-person outpatient group? And fair question, for any of us who care about our clients and students and patients, that is a great question to ask. Efficacy, we want to know. So since we've been rolling with this, and we do a lot of studying on what's going on. Hazelden, of course, has our Butler Center of Research. And so we are big into evidence-based practices, that we are driven by that. And so we've been tracking this really, really closely. And it's been so exciting, because what we're actually seeing is that not only is virtual outpatient as successful as in-person outpatient, it's actually been more successful, because it gets rid of a lot of barriers that we'd struggled with patients in the past. Things like, how do I get there? I don't have a car, maybe there isn't public transport that gets there, nobody can give me a ride. Those were big hurdles. It's really tough when you're struggling with depression and anxiety and a substance use disorder to say, you know what I'm going to do? I'm going to get in my car and I'm going to drive and I'm going to go to my treatment group. Now, all they have to do is turn on their computer. They don't even have to put real people clothes on. They can stay in their pajamas. All they need is access to internet. And so that's been really cool. We're seeing much higher rates in attendance. Patients are sticking with treatment for the full length of treatment. We are seeing far fewer against medical advice discharges, which is fantastic. And we're seeing a way higher rate of patients then staying in the continuum of care and stepping down into extended outpatient, or then also being willing to sign on for our virtual mental health services. And then family members wanting to stay engaged, and so then they join in our virtual family program. And so it's been a really, really cool way to actually beat some of the barriers that we've had in the past. And so that's been super cool. And in speaking with our clinicians who are doing the work, one of the big questions we've been asking is, how's your engagement? Is it harder to feel engaged in a virtual setting? And some of the feedback, the responses we've gotten are actually no. They too anticipated it might be different or more difficult, and it actually hasn't been. And so the clinicians have been really excited about that it feels as good as in-person has. And just some kind of speaking points to, as you all do virtual services with young people, there are just a few things to kind of keep in mind when we're transitioning into this new virtual realm. Is things like eye contact is much more difficult virtually. And so one of the things that we have to do is, it can be really easy to want to kind of look down at the screen at other people's faces and to feel like you're speaking to those people. However, then if I'm looking down at other people's pictures, it doesn't look like I'm looking at you. And so one of the changes is it's kind of awkward as the clinician or the presenter to feel I'm just staring at you at this little camera. I'm just staring at a dot. But it feels more connected on the other end. And making sure that you're being mindful that we don't have as much body or energy awareness when we're working virtually. And so being more verbally communicative and giving more verbal kind of nudges to our clients. You know, you said you were doing okay. Are you sure you are? What are some things that are going well? Making sure we're asking even more questions, and so they feel even more connected. But I thought that was super cool. We're several months into the pandemic now. We've launched our virtual services in many states across the US, certainly all the states where we have physical brick and mortar facilities. We just launched last week in Colorado. We are serving in California since we have brick and mortar there. And so all we've really had to do now since we had it set up is get our licensed clinicians in each of those states. And so it's been really cool. So I think those are kind of the three main things that came to my mind when I was asked to present today is what's happening with their brains. We got to make sure we're thinking about what's developmentally appropriate and that we're watching those behaviors. The other thing is understanding that mental health and chemical health are in this together, unfortunately, and there's more isolation happening. This virtual world is exacerbating all of that. And that thirdly, these virtual services are really working. And so it's actually a very exciting time to get our clients and our students and our patients engaged in these services.
That's wonderful, Kate. That was very informative. And not only that, you kept time. I'm proud of you. Okay, shall we hear now first from, is it Asha? I've lost my list. And do you want to tell us a bit about your externship?
Sure. Courtney and I were going to jointly present.
Oh, that's okay. That's okay.
Okay. Yeah. So we'll go ahead, Courtney, if you want to share the thing.
Yeah. So we'll share our PowerPoint. So give me a second.
So what level of medical school are you, both of you?
I am in my 4th year, applying for residency right now, and Courtney's in her 3rd year. She just
Wonderful.
finished vascular surgery rotation.
Great. And when did you go to Betty Ford? Did you go to the one in Rancho Mirage?
Yes, I went in 2018, and Courtney was there, I believe, 2019.
Yeah.
Okay. Okay, off you go.
All right.
Okay. So like Asha says, so the Betty Ford Center, they have a medical student externship. It's open to really any level of medical students, either 1st, 2nd, or 3rd years. In my program, we had mostly the summer after your 1st year, but there were some 3rd year medical students there. And it's just 1 week. You live down in Rancho Mirage in the hotel, and then every day the Betty Ford Center, they come and they pick you up and they bring you over there. And then you spend the entire day there just learning about what they do and about their patients. And you get to go to their 12-step meetings. So we'll talk kind of more about the program in a little bit more detail here.
Yeah, so exactly what Courtney said. We both participated as medical student. They called it a fellowship at the time. So I called myself a medical student fellow at that time. But yeah, exactly what Courtney said. It's a week-long program. We live in a hotel in the area for that week, and we participate in either inpatient or outpatient addiction treatment services. And basically, whatever service you're paired up with, you continue that service for continuity of care for that entire week. So if you're on inpatient, you stay inpatient. If you're on outpatient and you see the daily meetings, then you go to the daily meetings. Yeah, so what we did as medical students was actually very interesting for that level of education that we were at, because we were actually more participants than actually providing any services, which is what we're used to doing as medical students. So it was a very interesting opportunity to see that side of addiction treatment when we know when we practice, we will be on the other side. And I think that's a very important perspective that we were able to develop through this process.
Okay, so kind of the overview of the program. So as we know, addiction's a biopsychosocial spiritual disease. So Betty Ford really focuses on treating the whole person. And you really see that in the program. They use 12-step meetings. They're also using group therapy. They even have like an exercise room for patients. They go to lectures. They eat lunch together. So they really spend the whole day, you know, really trying to treat every aspect of the person. And like Asha was saying, it's really an immersion program. And so we would go to all the therapy sessions with our patients. So we would each be assigned a patient, and you kind of follow that patient during the day. So you go to their group therapy session, you sit with them in lectures, and then you eat lunch with them. And then, so you're essentially just like learning about them the entire time that you're there. And it really does become a safe space for everyone to share their experiences. So part of the application process for this program is, I would say maybe like one person in my entire group of maybe 15 people had no idea or no experience with anything with addiction, but most everybody else had a family member who had struggled with addiction at some point in time. So it really became this place where people got to talk about you know, how that had affected them in their entire, you know, life, essentially, in a way I think that most medical students hadn't really shared before with other students. And so you're just in this really unique situation where you're with like a bunch of people who are doing the same thing as you. You're all in medical school, and now you have this other thing that that you all share, which is, you know, being affected by addiction in some way.
Yeah, and so parts of this PowerPoint were actually provided to us by the fellowship director, Joseph. I never knew how to say his last name, Joseph Skrzyjewski. He's amazing, but he helped provide some of this information. So this is some feedback that the program's been given. And I think the main point that we're trying to make is seeing addiction treatment from the other side is a very critical part of medical education. We need to be able to see what it's like from that side in order to be able to address it appropriately from the doctor side. And yeah, like Courtney said, we were participants, and most of us, if not all of us, had some kind of connection to addiction. So it really was a place where we talked about things that we had never talked about before, addressed some deep-seated feelings that we never had acknowledged before. Courtney and I both cried for several days during the program because we learned a lot about ourselves and our relationship to addiction, and how important of a role the medical provider can play in treatment. So yeah, this is just some feedbacks from some participants we wanted to share.
So kind of like what we wanted to accomplish before going into the program, I didn't entirely know that it was going to be such an emotionally charged week. So I kind of initially had thought I want to learn about like, what does the Betty Ford Center do? How do they operate really on a day-to-day basis? I grew up in Moreno Valley, so it's out here near Riverside, which is very close to the Betty Ford Center. And I, you know, I've always known about it. I knew it was there, but I didn't really know what they did. So I think for me, it was more of like, what do they do over there at the Betty Ford Center, and how do they treat patients is kind of what I was thinking I was going to get out of the program. I didn't think I was going to get any of the emotional stuff that ended up following.
Yeah, I completely agree. I wanted to learn about the Betty Ford Center. I'm going into family medicine, and I have a very strong interest in addiction treatment. There's an addiction medicine fellowship for one of the residency programs out there that partners with Betty Ford Center. So it is something I'm interested in addressing in my future practice. But yeah, so I wanted to get the connection with Betty Ford. I wanted to see what it's all about. It's a beautiful facility. I did not expect it to be as immaculate as it was. It was amazing. And I wanted to see, like I've kind of touched on before, what it's like to go through treatment. And I think that it's just as important to learn about the experience for patients as it is to learn about the pharmacology. So we did get some lectures on the pharmacology, but most of it was patient experience, and we followed our patient around all week and participated with them. So I think what I wanted to accomplish was accomplished. I wanted to learn about the Betty Ford Center, kind of learn what are the different steps of addiction treatment, and what the experience is like for patients, and all of that and more was accomplished.
So here's some of the program expectations that they had. Obviously participating in all the programs, really immersing yourself in the group. So going to all those therapies sessions, going to lunch with the patient that you've been assigned to, being open and authentic, which we talked about, which is why me and Asha had a hard time in the group therapy and talking about like our experiences. And having the other patients share in group therapy also was, helpful to encourage us as medical students to share. The only reason I shared was because the therapist saw me. I don't know, she's a therapist, so she knew what was going on. She could read my body language, and she asked me if I wanted something to share, and then I just immediately just start crying, so she knew there was something there. But there was such a safe space for all of us to, share our different experiences. Like, I wasn't struggling with addiction, but my sister was. So that was something, I got assigned to a patient who was 24, who was the same age as my sister when she was using. So it became this very emotionally seated thing. And I was able to really talk about that. And that was really cool. And I think we kind of talked about this. My expectations of the Betty Ford Center, since we've always known it was there, I knew it was kind of a place that, either rich people went, celebrities were there. I thought it would be more young people in treatment, but little did I, come to find out it was, they actually are taking insurance. Not everybody is super rich who's at the Betty Ford Center. You have young people, you have people really just like of all ages there. You have nurses, you have doctors, there was even a medical student there when I was there. People who hadn't gone to college. So just really, really the gamut of people you find at the Betty Ford Center.
Yeah, completely agree. The patient population was a little different than I had expected. And I thought that the way that they talked about addiction there would have portrayed it in a more glamorous way, and I'm glad that it didn't. It was very real, very honest, and it's pretty amazing because as future healthcare providers, we are taught how to gather history from patients, and a lot of patients are very guarded, and it's kind of tough to get information from them. But for my experience with the patients that I interacted with, even before knowing my story and my family members' experience with addiction, they were very open and very willing to aid in our education. And when I became emotional, very supportive. I was in one of the houses, I did inpatient treatment, and I was in one of the ladies' houses. And most of them were older, I would say over 50, because I think from what I remember, they separated it by age group also, because there was a younger women's house and an older women's house. So when I shared my experience and my experiences with my mom, it was very touching and almost unbelievable how supportive they were, because I had held a lot of resentment for what I experienced as a kid with my mom. And I was very raw and honest about that, to the point where I felt like maybe I could be hurting some of their feelings, because they have kids, and one patient in particular reminded me exactly of my mom, and she explained her experience with her daughter after starting treatment. So I was able to be really honest that way, and they were extremely supportive, much more than I had anticipated. So that's not something I expected at all. That level of support when we're there to learn, but they allowed us to be such integral participants, and it was amazing. Yeah. So again, this stuff was not what I expected being able to do at the Betty Ford Center. I thought we were going to be in the corner. We were just shadowing. We were going to be with the physicians all day. I didn't expect to be this immersed in the program. And it was a very wonderful surprise because I actually dealt with, I mean, it was only a week, so we're still, acknowledging some emotions by the time we leave, but I felt like I addressed a lot of things that I had never acknowledged before emotionally. So being able to be that involved was an amazing opportunity.
Yeah, so I guess we really just talked a lot about this, just the non-judgmental ways that everybody, interacted with each other, self-disclosure to patients and family members, people laughing, crying, engaging, like that's really just all what the program was entirely about. Which makes it such a unique program. Usually as a medical student, when you do these summer externships, you go shadow a doctor, you do research, or you do something very much on the physician end. But I think we met maybe one physician for 20 minutes, so it was not focused on how you treat this as a doctor. It was really like, what do the patients look like, and you really need to see their story through and through before you can even go start thinking about treating them. So now these students who do the Betty Ford Center, they have so much more insight, not just, oh, what medications do you give for somebody overdosing on opiates. So it gives you really this really deeper understanding of addiction. Yeah, so one something I wanted to talk about that I thought was more relevant to collegiate recovery. There was a medicine recovery panel, so there were patients in the Betty Ford Center at the time that I was there who were doctors or nurses or veterinarians, and there was one medical student, and so they came onto the panel, and the medical student had actually done the Betty Ford Center the year before, and now he was there as a patient in treatment. And I thought that was like a really powerful experience to listen to his to him talk about, like, the types of opiates he was using, just to get through school. And it really became like, it was the first time I think the first time I had seen at the Betty Ford Center a college student there, because you don't really think of somebody who is, a successful college student, they're in medical school falling to addiction. So I think hearing his perspective of how addiction kind of, made its way into his life and got him into the Betty Ford Center in his third year of medical school, really like resonated with a lot of the medical students there. And then the patient that I was assigned to, she was 24, so she was also a young person, but she hadn't gone to college. She had been using for a long time. So it was interesting to see that, the two very different types of young people that you have at the Betty Ford Center.
Yeah. And for me, I would say the most successful experiences and interactions that I had were not just with the patients, but with my cohort at the Betty Ford Center. All of us had really serious experiences with addiction and with very close family members, sometimes significant others. And being able to build that bond with them, I still talk to them now. I mean, most of us were in the same year, so we're all applying for residency now. We're still friends. So being able to build that connection with people who have experienced similar things and have similar goals was incredible. All right, so group therapy was one of the major aspects of treatment that I had an opportunity to see at the Betty Ford Center. And I think this is where, I mean, I got a lot out of the whole program in general, but I would say I got the most out of group therapy. There were several different techniques that the therapist used that I've never learned about before or ever seen before. I mean, I see a therapist on my own, but I've never seen those kinds of techniques. And it was all very open and non-judgmental, which was incredible to see with so many people that are experiencing like a really severe disease. And it was interesting because they had people who were like nearing the end of their treatment and people who were just starting. So seeing their interaction also and supporting each other was great to see. But yes, like I kind of described before, I was in the same group all week. So I got to build a really strong relationship with those ladies. But because of, you know, like patient confidentiality, we didn't give out any contact information. So I wasn't able to, you know, see what happened or provide continuity of care, which is something that I missed. But that's going to be my role as a doctor. So being able to see what actually happens in inpatient treatment was a good experience.
Yeah, so we've talked quite a bit about this, I think, now. So we our main job was really just to share our perceptions, our insights. We also were told never give advice, which I think something maybe I felt like I struggled with because I think I was always trying to help my mom or my sister or give people advice. So, you know, when someone would say something in group therapy, I would have to be very careful to like not say something back and just really be a listener. And I think that was it was really helpful to just have to sit there and just listen to somebody, even if I wanted to say something, whether it was advice or, you know, anything it was, you just had to be quiet and just listen to what someone else had to say. So, I think that was really helpful. Yeah.
Can I ask a question?
Sure.
Why did they say not to give people advice?
Why did they say? Well, I think it was more like they don't want the medical students coming in there and trying to tell people, you know, give them advice on their treatment or give them advice on anything like that. Or like, oh, you should have done this or that type of thing, you know, because as medical students, you're kind of taught to give people advice.
Right.
Yeah.
Thank you.
Yeah, so we've talked about this quite a bit, our experience in group therapy. Courtney, if you want to talk a little bit more about it.
Yeah, I think in terms of time, we can continue.
Okay.
Some of the additional program elements that we had that I thought were kind of cool that made you really feel part of the group is you got this camel pin that was like your introduction to the group. So now you get to wear that on your white coat when you're in clinics and things like that. And at the very end, they do a coining out ceremony for the patients. And then on our last day, they also did it for us. So it was just this other way of them really making us feel like we were really involved. And then some of the other kind of lectures that we got, drugs of abuse and co-occurring disorders, because we know mental illness and substance abuse really can go hand in hand. The professionals meeting was the one that I talked about with the doctors and the veterinarians and the medical students. So we got really a variety of different activities.
Yeah, and just some more additional things that we got to do. A lot of these here were lectures that we did with patients, so they weren't like specific medical student lectures. So seeing how they reacted to this information was actually really cool to see also, and being able to relate to them by talking about these lectures afterwards, like during lunch and things like that. Yeah, so we did Bag of Rocks. We learned about family dynamics because of the family program that Betty Ford has, spirituality in recovery, finding happiness in recovery, grief, and stories of resilience.
So the inpatient experience is what we had. So they also have a day treatment program, but neither me or Asha did that program, so we can't speak to that. But the inpatient experience is kind of what we've been talking about, where we were each assigned to a female hall. So all the people in the group it was all women, and like Asha was saying, different phases of their recovery, from people who have just gotten started to people who have been at Betty Ford for a few months, or there are people who had been in and out of Betty Ford a few different times. So people really in all different phases, which I think helped them help each other, really having people who are at different levels. And yeah, so we've talked about just the other few things here already. And then really the experience, so we really gained insight for the drivers of addiction and all the different types of people that Betty Ford had, all the different patients that came to the Betty Ford Center, really the power of being vulnerable and like opening up and talking about how addictions affected your life, and seeing how patients had to just accept what had happened and they're just working on now moving forward. Yeah, making strong connections with the patients and other medical students, hearing stories, really helped us better understand what our family members had gone through when they were in treatment, and how, as physicians, we'll be able to further advocate for our patients who are struggling with addiction.
Yeah, and so like Courtney said, neither of us participated in the day treatment. We were actually assigned which type of treatment we would be seeing for the week. So neither of us had that opportunity. But one thing that I just wanted to mention about the day treatment is, in addition to like the actual Betty Ford inpatient center, they have like a compound like right next to the Betty Ford Center, where the people who are transitioning to community living and kind of finishing up their treatment, they start to live there as opposed to on Betty Ford, and then they come in every day for day treatment. So Betty Ford, they provide everything you need for successful recovery. And I think it really empowers patients to feel like they're being taken care of, and makes them more willing participants in their treatment, which is one of the most critical factors in successful recovery. Yeah, so we've basically been talking about our conclusions along the way. I think neither of us expected for us to be as involved in the treatment as we were, and I think we didn't expect to connect to it so personally. We're taught as medical students that you have to have a healthy boundary with your patients in order to maintain your emotional health. But I think this experience helped me realize that one of my strengths, and Courtney's strengths as well, is being able to empathize and relate to people who are going through things that are very different than you, and being able to communicate with them in a way that's empathetic, and kind of being humble and having some sense of humility, that everybody, addiction affects every generation, every type of population. It doesn't self-select. So yeah, I think we were much more emotionally involved than we anticipated, which was a good thing.
Yeah. Okay. Thank you so much, girls. I'd like to now introduce the panel, and let's see, I have to get out a full thing first to do this. We have 3 people here with us today who will start off the questions or the comments, but I can't find the list. We have one person from UCR, Alton Carswell, who deals with college, with students. That's his job. He's a caseworker and a licensed clinical psychologist. We also have Dr. Melinda Drake, who's the director of MFI Recovery. MFI is a very well-known program in the Riverside County area. They have about a dozen facilities, and several of our students have been through their programs. And we have Desmond Young, who's the director of Riverside Recovery Resources, which also is a very pivotal treatment and program in the area. So perhaps we could go one by one and see what comments you have about treating college-age students or questions for our presenters. Alton, would you like to kick off?
Yeah, sure. I just want to give an overview of how we provide services for students at UCR. So case management, what we do is connect students to resources on campus and actually assess what they're dealing with in order to problem solve with them to provide them those resources. So I'm glad that we're able to provide some input with this topic, specifically working with students of various backgrounds and also students that are dealing with recovery issues as well.
Do you think, because Riverside has a very diverse student population, do you find that students from different backgrounds have a different approach to either their struggles with addiction or their needs for recovery?
Yeah, it depends on how. So in my work with them, I'm usually depending on what a student's coming in with during my initial intake. I usually ask them questions around their issues specific to recovery or use, and what their identity means to them, specifically on the college campus. So some of the issues specifically around identity that I see are with students in the LGBT community. Transgender students who are working on a transition can come in with issues around substance use because they're managing their identities and trying to figure out where to move from there. Other students that I deal with are students who are dealing with external stressors. Specifically now during this time, we've got COVID and online learning environments. So with those students, again, I kind of explore how their navigation with these technologies and with their school overall is affecting them, and then kind of explore the identity piece. So specifically looking at, besides the transgender community, one of the groups that I find has been coming in a lot more with students with a Latino background. So those students are having, some students that are dealing with a lot of issues around the DACA issue, an immigrant issue, but also students who are dealing with family members who are passing away. So we're doing a lot of bereavement services specifically for those students. And exploring and honoring the memories of their families when working with them. I liked what you said, the two earlier had mentioned around just having that empathy and really connecting with the students. With my therapist background, that's one of the things I really want to kind of put forward with many of the students, just being that face, being able to engage with them and listen to their stories allows me to connect with them and then further explore more along the issues that might be sort of impeding their ability to provide or to act in their academics or engage in their academics. So that's one thing. Also working with students from the African American community, sometimes there's been issues around the BLM movement and everything that's happening right now with that community. With those students, really sitting down with them, again, engaging with them about their identity and what that means to them within the college environment, and if there are any stressors that they feel are impeding their ability to engage. So what I mean by that is some students are losing their motivation across the board to complete their programs. So one of the things that I do with those students is, re-engage them in what was your initial goal for this degree, right? And what are some things that we can do and steps that we can look at right now in the moment that you can focus on from week to week versus 2 years down the road? Because right now, because of the COVID issue, a lot of people are having a difficult time just staying focused on their initial goals, right? And by focusing on the steps that they can do in their initial goals for their degree, for that quarter specifically, that allows them to kind of not kind of think forward and lose their motivation in that way. So those are some things that I'm seeing at this point.
Great. And Dr. Drake, perhaps you could talk to us about your issues with younger patients at MFI and whether that's changed in the last 8 months or so.
It is kind of funny that Alton mentioned something, the students losing motivation, because I've actually had some students who were planning to go to UC Riverside who decided to take a break and not start college this year. I don't know whether this is like just something new, but that's some of the things that you're hearing. And it's actually not just one or two, but even, you know, students who are in high school graduating and is planning to not go to college right away, that you're actually seeing that. And like I said, because of COVID, this is actually the first time in years that, nicely, I'm a licensed clinical social worker, so I can actually see clients too, which is great. And because of that, and because of COVID, I actually ended up seeing some clients in the last few months during COVID. And this is some of the things that I've seen in the few clients that I've actually seen. And I'm looking at it on the part that this is just the few clients that I've seen, and wondering as to whether that is a pattern, which is kind of funny that Alton mentioned that in one of the students that he's working with. It's true that their brain is definitely not in the same level as somebody who's, you know, who's fully formed, 25 and up. They're still changing, but there is, I think, something that we really have to realize this year is that something extremely different happened. You know, COVID hit us, and their life experience is gonna be very different from anyone before or anyone after. I don't think we've ever had a group of people who've been robbed of, you know, pivotal experiences in their lives. You know, this will be the first generation that didn't experience a prom. This will be the first generation that didn't experience a graduation. These were normal steps. Now, these were normal pivotal things that happened to every one of us. And this generation didn't get that. And so you look at that, and we've really not talked about how would that impact this generation. And to talk that, you know, I've been teaching online classes, gosh, since 1999 when I was in South Carolina. And although it is good, it's not the same. Because whether you like it or not, the biggest and most important thing about school is socialization. And you don't get that talking in a box. And I even think about that. I think we provide at MFI, we have been providing, telehealth services across our system, from our residential to our outpatient to our sober living, every which way you look at it. And yes, I've been able to connect with people just as well online as I would, you know, face to face. But again, this is not who we are as humans. This is not our natural way of relating. And there's always going to be a part of me that will question, you know, whether it's really as good as we believe it to be. We all hope that it is, but it will be years before we find out whether it's really as good as we think it is.
Mm-hmm. Well, encouraging perhaps to hear that Betty Ford has had good success with their online patients. Maybe that's a little encouraging because it is a frightening time. Desmond, what have you been seeing out there?
What have I been seeing out there? Hey, what have I been seeing right here? This is amazing. You guys are amazing. This conference is amazing. And what I've heard has been just absolutely beneficial for me. I want to thank you again, Ms. Francis, and then Kate for your lead there. Great information. I took a bunch of notes, and I heard some things that I was not aware of. And you two up and coming doctors there, Asha and Courtney, hey, just about what you guys are going to be able to do. And I just love listening to you guys. Just briefly, I'm one of those straight out of Compton. I don't say that any kind of way because I'm not a victim. I'm one who was I was pre-med. My third year, I met alcohol, and I'm one of those that didn't finish and didn't go back. Obviously, I, found another way, but for 20 years, I was out there, under the illusion, just because I had money, that everything was okay until it wasn't okay. So it really touches my heart. I've never blamed anyone. It was all on me and so forth. And I learned that even better getting into the recovery world. But you guys give me hope just to know that we are in crazy times. And this is something that none of us really know how this is going to turn out. But what we continue to do is to do our best. As I like to say, one alcoholic or addict at a time. I think a lot of times people forget that people are dying. We can talk about we're there, we see it, but when you're talking to that 18-year-old, I've talked to an 18-year-old in the riverbeds saying, hey, I can get you help. I was going to send them to Melinda over at MFI, but no, I was able to get her help, and just to see how she wanted to stay there is, you can only help and lead a horse to water, that kind of thing. But it is important to be able to build these relationships and plant seeds, because we never know when that pain will get great enough for them to shift. So yeah, I guess the first thing, I'm just overwhelmed with not so much of what I can bring to the table or the organization I represent. I represent Riverside Recovery Resource. It is a nonprofit that's been around since 1985, helping in this space. And I continue to look for opportunities to see how we can just be more community engaged. We're part of newly formed, I'm on the board of Inland Empire Harms Reduction. And that's totally different for someone who's in the recovery space who said, hey, abstinence. But you know what? I grew up, I learned from you guys. I learned other things that are working, and that's what we are doing. So yes, I could probably pause here and think about a lot of other questions or things that we have done. We're seeing it all. We're all seeing it. But I guess my biggest thing is just saying, recognizing them, seeing them as individuals, customizing what that need may be. Sometimes we just herd people and think that, okay, they fit this model. But sometimes we need a subtle little shift for that individual to help that individual connect a little deeper. And I think you future doctors here are going to be able to do that in your space. And obviously everyone else here has been working in that space. And I'm just glad to be a part of this with you guys. Thank you.
You're muted, Francis.
Can someone unmute her?
Yeah, I did it. That's my tech advisor, Maya, making sure I don't get into trouble, which I always do. I'm just wondering how you young doctors will feel that you will see patients differently in your practices because of your experience in the recovery program, and especially the younger people, especially the college age people who are your age. What difference do you think it's made?
I think it's already made a difference. So I'm a third year now, so I'm just started in the hospital doing rotations this summer. Asha's already done her rotations in the hospital, but one thing I can think that sticks out for me right now is we had a young patient. He was 30. He came in for some heart conditions caused by his cocaine use, and he's used enough cocaine that now he's hospitalized for it. And you just see a lot of the doctors and the residents just kind of brushing him off, being like, oh, he's here because he uses cocaine. And he immediately gets this, I would like to say they don't treat him differently, but the attitude is absolutely different when they talk about him as opposed to they talk about somebody else whose heart's failing for a different reason that's not cocaine. And so I think just kind of that inherent kind of stigma that people have about people who are using drugs and who are having medical problems from it. I don't think they get treated as well in the hospital. I don't think people care as much about, what happens to them when they get out. And I think for other reasons too, we've also had I've seen patients come in who are high on methamphetamine or something into the trauma bay, and then they just run out of the trauma. That happened one time. They run out of the emergency room. That happened one time, and everybody is just like, well, of course he's using drugs, why wouldn't he leave? So I think having these inherent stigmas and that being okay, nobody thinks twice about it when someone says something like that, right? They're like, of course, everyone is kind of on board with that. So I think seeing it from the other side and having also family members who have been affected by drug use, those aren't your immediate thoughts when you see those kinds of patients, right? I don't think those things when I see the 30-year-old kid who, has a heart condition from his cocaine use. I see my sister and I think like, that's really sad. Like, I hope we can try to get him connected to other resources, or, you hope that if someone has to be hospitalized for something, that maybe this can be where they are like, this is going to kill me if I don't stop. And then you are going to be there as a doctor to say, yes, this will kill you if you don't stop. And look where you are now. And these are the different kind of 12-step programs. You can find AA meetings here. You can find NA meetings here. Anybody can help somebody find an AA meeting. They have websites. Like, it's, those things. You don't have to be a doctor. You don't have to be any highly educated person to give those resources out. But I don't, that hasn't been something I've seen physicians do to any of these patients who come in with these kind of substance use disorders.
Absolutely. I 100% agree with the perception of people who have addictions in the hospital. They're treated very differently, and the tone is very different when doctors talk to them. And I think, especially because I'm going into family medicine, I 1000% agree with what Courtney said. We are in the position to provide them the resources. One thing that I wanted to mention about Betty Ford Center is, I talked a little bit about the resentment that I held on to for a very long time and didn't really acknowledge. So before that experience, I would say my perception of people presenting to the hospital for medical conditions due to a drug addiction was very much like, well, they're doing that to themselves, like how most doctors think about addiction. But in acknowledging my resentment and seeing so many people going through treatment and them being so welcoming to me, and being so open to my thoughts, no matter how harsh and unfiltered they were, having gone through that, my perception of people who come in with addiction is like what Courtney said, like, I see my mom. And I think we need more physicians who think that way, because we're not just treating medical diseases, we're treating whole people. And I think I'm coming from a perspective of someone going into family medicine, so I already feel that motivation. But it is a culture that needs to shift. And I think the more education's out there, the more people will try to acknowledge their bias with people with addiction.
One of the things that occurs to me, someone in the morning session asked the question, about training of doctors in addictive disorders, because certainly my impression and that questioner's impression was that there was very little training. And it seems, just as a complete civilian, if you like, quite shocking to me. The neurological studies these days show that that there is a genetic difference in people who become addicted to drugs or alcohol or even behaviors. And I'm a little astounded, I think, that our doctors in training aren't getting more of that, and that they're still with those old-fashioned stigmas.
Yeah, we get very little training. We have a psychiatry block, and that's kind of where it comes in, but it's maybe 1 hour. And it's very, very minimal. Me and Asha only got to go to Betty Ford because we sought it out ourselves. I knew Asha did it because I've known Asha since we were like 5 years old. So I knew I knew that Asha did it. And then when I came to school, I was like, I asked her about it. So I really only did it because she did it. So there's not much training at all. If you go into, there is addiction fellowships that you can go through, I think, either the family medicine route or the psychiatry route. And I'm thinking about psychiatry. So you could go to do that, but that wouldn't be until you have been completed medical school, you have completed your residency. So now you're 7 to 8 years into training, and now you're getting an addiction medicine fellowship. So, but before that, you don't get anything really specialized in it. We did have one question in the chat from Stephen about alternatives to 12-step programs. I like this question always because my sister actually didn't go through a 12-step program. She went to Teen Challenge, and that's a free year-long program. So if anybody wanted an alternative to a 12-step program, I always tell them about Teen Challenge. It's a Christian-based program. We weren't particularly religious growing up, and she still went, and they still accepted her. And I do know I don't know if Salvation Army is 12-step, but I know there's other, at least church facilitated, faith-based, I guess, programs out there that aren't necessarily following the 12 steps.
Salvation Army is very 12-step, but of
it
course
is okay.
It's also very Christian.
Okay.
So going into the Salvation Army, you're going to get a little bit of Bible stuff. Do we have any other questions?
Stephen has another question about.
Sorry, I was just going to also speak to the 12-step question, because we are a 12-step based program, and so we actually get a lot of pushback. Particularly, I've been working at our adolescent and young adult facility for many years, and there's often pushback around that because there's kind of this stigma with the 12 steps that it's for old Christian white men, and because that's who wrote the big book. However, again, we are motivated by evidence-based practices, and so we use what works. And so we use the 12 steps because the reality is the 12 steps have gotten more people sober than any other treatment modality in existence. And there are a million ways to do the 12 steps. Right. And you don't have to be religious. You don't have to be faith-based. You don't have to believe in God to do the 12 steps. We've got a book in our library called The 12 Steps for Atheists. And so the reality of the 12 steps, it's a way of looking at yourself and a way of connecting with other people in a really authentic way. And so I think a huge piece around that is just education for patients at the 12 steps. If you are a religious person, the 12 steps is a religious program. If you are not, the 12 steps are not. And so it can really fit who you are and what you're bringing into the treatment room. So I think the education piece is just really important.
Right. I do agree with that as someone who's been in a 12-step program for 30-odd years. I find a dichotomy there because, in fact, not only was it started by white Christian middle-class, middle-aged men, it was based on the Oxford group, which was a Christian program. And while that doesn't bother me particularly, but I don't like the sense that anybody else would push their form of religion on me. But I am aware that it does sound religious because it talks about God, even if it's not about a religion. And yet I'm aware that within the program, we don't require anybody to have any belief in any deity at all, just to trust in the process. And I think that's one of the reasons why we don't give advice. I thought about that when our medical students were sharing, is that one of the greatest gifts that I found, and that I think that we give to people coming into the program, is we listen. We listen. We listen attentively, and we don't give advice. You know, they have their path to follow, and it's not our job to tell them which way to step. But it is a dichotomy in the program, and I do understand people who are suspicious of it, because I was suspicious of it myself. If I hadn't been so desperate, I never would have allowed people to talk to me about God. I think we lost Kate. Did we lose Kate? I think we've lost your, have we lost your sound, Kate?
Here I am. I'm back.
No, that's okay. That's okay. How about the rest of you? Do you get pushback on the 12-step concept? Or do you offer other approaches? Because I know there's what is it called? Rescue recovery, or there's a Buddhist-based one. There's of course AA for atheists. I mean, there are meetings in the inland area, not very many, but there are AA groups for atheists. But yeah, go ahead.
So there's the SMART program, there's the life process, there's a bunch of other, should I say, modalities toward dealing with it. But I guess once, whether it's personally embracing the 12-step program, and as already acknowledged by Kate, it has been now shown to be the most effective.
Right.
Like in most cases, and again, I'm saying it from a insider space as well. And mind you, I never wanted to be in the business of recovery at all myself. And this just happened within the last 5 years. But I can absolutely say that now that I've been in with some amazing people that are able to keep it separate. There's this business of recovery, and then there's personal recovery, and they're two totally different things. But like the gentleman that also that asked about advice, and Ms. Francis just said, hey, you know what? The best thing, I don't know what it is about me, but as soon as someone's telling me what to do, I have an issue with it.
Right.
What's going on with me? Yeah, it's my problem. But as soon as you share with me what you did, all of it works. So I think that's what's so important about in the recovery space, or working with these young minds that I didn't know, Kate, that they weren't developed still. I personally have a 22, a 23, and a 25-year-old. And I'm happy to say that my 25-year-old, she's working on her master's, and my 22-year-old, he's a graduate of West Point. But my 23-year-old, she's in total denial and wants to smoke weed and doesn't see it, and she's an artist and all this other stuff. And so again, they were in the same environment. They have a mom and dad that's been present with them despite my experiences personally, but present for the last 16 years, always able to provide for them. So what's going on there? And it's just like everyone's individual. Everyone has their own journey. And yes, there are some other genetic factors that I believe are in play, but the reality, it comes down for me on whether or not I can face reality. Am I able to just see reality? And that's what I find that when I'm talking with young people, especially, and I'm not thinking of my kids, that they have all the answers, right? Despite the years of experience you may have on them, they still know better. How at 20 years old, and how do you combat that? Well, press on, go experience it, and then come back. So I want to get off my soapbox, but
good soapbox.
Anyway,
I wonder what Kate and maybe Melinda have to say about how differently to approach these young minds in treatment. Because I understand that they're undeveloped, and I understand that their prefrontal cortex isn't fully developed, but then how do you approach them when they're dealing with this disease?
So oh, go ahead.
Well, the new things actually not so new, but I always talk to people about when you stop using, all you are is you stop using. Recovery is not just not using. And the one thing that we have done since I moved to Riverside about a year and a half ago is really embracing the whole idea of a whole health approach, that you are what you eat. So you need to start with, you cannot change the brain if you do not change your diet. Having a dopamine-rich diet is essential. So bringing in chefs so that you will have the right food to have for our residents was a big deal for me. That's not enough if you're in residential, that you have to be active. Having that activity, because if you look at the word emotion, the root word of emotion is motion. And having that whole health approach of not just the 12-step meeting, that's part of what we do, but it's not all of what we do. We actually have moved to the idea that right now, more than any other time in the last 3 decades that I've been in the field, we have more information now about the human brain than we've ever had in the last so many decades. But at the same time, we still don't know enough. But what we know is that the brain is still changing. And so that in itself is such a new gift for all of us, to know that there is a promise that we can change at any time. The young minds are, yes, they're not quite developed, but guess what? The older mind, when you're after age 25, it didn't stop developing. That's still developing. That's still changing. So that is just as good a promise as, no, it's not quite done yet, cooking when you're a young person. So with that, MFI, though a lot of people think of MFI and think 12-step, we actually do a lot more than that. We have dealt with making sure that we have psychiatrists that sees our clients in all of our 4 residential programs. We have doctors and nurses in all of our residential programs. We have, like I said, chefs, although we are a medical program, that does not stop us from making sure that they have just as good a food as those who are coming in from very expensive programs. If there's something that I love about being MFI is that I do not want the idea of our clients being mostly medical clients not having the same treatment as those who will be going to an expensive program. That's one thing that I think I definitely want to make sure that they get that same treatment that anybody would get. Or I look at it this way: after so many decades, the only mantra that I live by is I will not create a program that I would not put my own family member to. And so as I grow MFI, that's how we live. That's how I live, and that's how all my staff live. That all of our programs should be the programs that if any one of our own family member need help, we would refer them to our program. And so when you do it that way, you really have to look at what works. And a lot of the work is really now coming into neuroscience, the changing of the brain, and whole health. And so a lot of the work we're doing right now is about whole health and making sure that we are not just addressing the addiction side, the mental health side, but also the physical health side. that you cannot separate those three things, because the addict is inside that body, and that body still need all of those physical health issues that they came in with. So many people, young and old, who come in our program come in with physical health issues that they have not addressed because of their addiction. You're just talking about not just diabetes, but so many other health issues that were unsolved because they were living in the river bottoms. And so for us, it is important to make sure that all of those are helping everybody.
A lot of the work that we do with young people to try to help keep them motivated when maybe that logic center isn't pumping the brakes on behaviors is we do a lot of values-based work with clients. And so part of it, what Dr. Drake was just talking about, is that whole health healing. And a whole and healing person is less likely to return to use. And so if we can help the whole person heal, then that's our best shot. And I've found in my work with adolescents in particular that if our work can be really values-based, that tends to help them stay on track, as opposed to thinking of the do's and don'ts of what should I be doing or shouldn't I be doing. And again, I'm the same way as I think it was Desmond who said maybe if somebody tells me what to do, I'm a 34-year-old woman. If somebody tells me what to do, I'm going to do the opposite of what that is. So then think about that with an adolescent. And so then there again, just instead of thinking about the do's and don'ts of what steps to take, thinking about things more values-based and what is intrinsically motivating to them as an individual. And I've found that to be really helpful.
We're having still a conversation, I see, about the 12 steps. And I think that John said he had something to add. I should say that some of the best research and the best data comes out of Harvard Medical School, where John Kennedy has done some John Kelly, has done some superb high quality research. But please, John, what did you have to add?
Well, we were talking about, or I was hearing about, the challenge of reaching people who know it all already, in particular this particular age group. And it occurred to me that I hadn't heard motivational interviewing mentioned, which of course is one of the very few evidence-based therapies that seems to be effective in treating substance use disorders. I also wanted to just say hi to Melinda, who I've never met, or any of you actually. Let you know that Desmond and I came up together, or met, and worked through this 12-step process together with a number of workshops. And that right before we met, I had just finished 106 days of treatment at MFI. So I did learn a lot more than 12-step. In fact, I never really learned the 12 steps at MFI. So there's that was worth mentioning for me. And then the subject of whether or not 12-step work is religious, and I would say absolutely not. That the mention of God is really a concept that that really ties in nicely with the notion that if I already know and I'm closed to evidence, then I'm in a really bad situation. And that, for me, even coming in as a somewhat Christian-based religious person, I had problems. I didn't have a problem with God. I had problems with whether AA was a cult, because it really wasn't giving credence to the right words or the right concepts of God. So I think for me now, by the way, having done 12-step work, found my way to wellness, I learned also that the biopsychosocial spiritual approach is essential to healing the whole person, and not enough attention is paid to diet in my experience. I'm a physician and I completed fellowship training in addiction medicine, and one of the biggest challenges that I see with patients, whether they be substance use disordered, adolescent, pre or post-adolescent, is compliance. Compliance is always an issue. And in substance use disorder, we don't even deal with patients yet. We're dealing with clients that are like customers. Right now, the industry allows them to come and go like they're shopping at Walmart, many times using treatment as a Motel 6 pass. And so once we get to the point where someone is really open and using their values and motivational interviewing techniques to really have them sit long enough, like minimum of 30 days of complete abstinence before the brain is working whatsoever. And for many, it takes much, much longer. And then at that point, maybe going to a 12-step meeting might be helpful, but probably not. In the school that I trained in, I was told, don't even think of suggesting someone goes to a 12-step meeting until they have at least 6 to 9 months of sustained abstinence, because the meetings are so triggering. So I think I don't want to hold the floor any longer. Thanks for inviting me, Desmond. This is, I hope to be able to follow your group in the future.
Did you have any other questions, Stephen and Alex, that you wanted to ask? We've got 4 minutes left. You've listened to us, so feel free to share with us now.
Hi there. My name's Alex. I'm an alcoholic, and
Hi, Alex.
hey, good to meet all of you. I'm just happy to be here and happy to listen. I joined late, so I'm just happy to listen. Thank you.
Okay. Stephen, did you have something? I saw you had an issue with stats.
Hi, folks. Yeah, I apologize if I sound like an expert in everything, but I do have, well, actually, okay, I'll do my ego thing. I do have like about 600 publications, and I've done a lot of work with addictions and stuff. I'm also an alcoholic and an addict, you know, which I've always been quiet about because, or tried to be quiet about because of the stigma. We had I'm at University of Southern California. You all may know we had well, now get myself in trouble because I have a big mouth. We have a former dean there who had a meth problem, and you know, it was pretty, you know, awful situation. He did the kind of things that folks do in the practicing, and you know, arguably, had he been open about it beforehand, maybe he claims manic depression, I don't know, but as well, but if he was open about it, would he ever have been able to become dean? It's kind of one kind of thing. So in terms of stigma, it's kind of blockages that people can go. And also in terms of AA, when I would go to 12-step meetings regularly to try to help myself, information, I'll just be honest, information went back to my workplace. I think people did that to try to help me. I think they were trying to do something good, but you know, I had, you know, talking about medical students, I was the secretary of a meeting. I only had 6 months sobriety at that particular time, and 2 medical students showed up at the meeting, and the person who was the guru, the local guru, was saying, you know, just share about yourself in a general way, which then made me know that he knew what was going on. They knew where I worked, and I tried to keep quiet about it. So there's plenty of, you know, the real world can enter in all that what we do. It enters in at Betty Ford, Hazelden, which has an incredible reputation. Part of the reason that places like Betty Ford, Hazelden do so well, I've read or I've heard, is because they have an incredible alumni system, because they've been around a long time. When you've been around a long time, you have a wonderful alumni system. You have all sorts of possibilities to help people with job placements and other kinds of things. It is that people factor in a way. But, you know, I mean, but there, you know, and but I do, you know, there are various different schools of thought, and 12-step programming in the US tends to dominate 2/3 of all programming. And it's possible that it's not right for everyone.
Yeah.
And if you're indoctrinated heavily into it, it's hard for one to believe that. They say, well, it works for everyone if you work it right. And I've heard, you've been at speakers meetings where you've heard people say, you know, it's the perfect solution to everyone. If it doesn't work, it's because you're not doing it right. You're not taking on a sponsor. You're not being, you know, you're not doing how, you're not, you know, you're not doing the 12 steps right. And, you know, and so, I mean, finally I said, you know, I hit 65 years old. And I said, I'll come clean, you know, basically, which means, you know, I'll just kind of open up about it. I mean, I have time now, but with everyone else who's in recovery like me, you cannot predict that you will never drink or use again. You don't know.
No.
I don't know. I can't make a promise to anyone. And that's a heck of a thing to say, because then why should anyone trust me with a responsible position? You know, but, you know, but it's a reality, but, you know, I'm doing well, but, you know, what does that mean? So, you know, I mean, we're dealing with really complicated stuff, and I don't mean to, you know, be a big mouth here and make things difficult. This isn't my conference. I'm just glad that I have the opportunity to attend and learn from you all. But, you know, I don't spout out generally, except, you know, things maybe that I've written somewhat, and I try to be as objective as I can. But, you know, for me, it's just been a trip. I mean, I've tried this thing since 1983, and I finally think I've got it together now. It's taken a long, long time, off and on. And I'm sure that I received a lot of support, but a lot of support I've received has been very covert and quiet and weird and paranoia making, and probably not good for my mental health. Of course, maybe I'm borderline Asperger's, and that could be another aspect. If I am, that would make it difficult for me to, you know, benefit from a network of people. So, okay, I'm done. Sorry, Francis.
Stephen, thank you. Thank you. We were happy to listen to you. My sponsor always says to me when people say, oh, there's only one way to do things and only do this and only do that. He always says there are many paths to the top of Mount Fuji. And that's based on personal experience. So yeah, there are many paths to the top of Mount Fuji, and we all have to find our own safe space, whether we're college students or post-college. But I will say that UCR, everybody, I used to work for the chancellor, not this one, the previous one, Tim White, and everybody on that campus, all 25,000 of them, knew that I was an alcoholic.
Well, my son's a sophomore at UCR. My son's a sophomore at UCR, and he loves it, by the way. And he's a normie. It just in his dorm room, if anyone's been drinking or smoking, they would when he was there, you know, they wouldn't let them in the dorm room.
Yeah,
so people weren't. They didn't want to have anything to do with. Unfortunately, he hasn't seen. I think he hasn't seen certain person, you know, create trauma in his life.
right.
In particular, but.
Well, everyone, and any last thoughts? We are out of time. I found it very, very, very informative. Thank you, all of you who dedicated the time to come and talk to us and help us through this issue. As you may know, if you've watched other parts of this program, we have been trying to waken UCR up for a long, long time to this issue. So hopefully the contributions from this weekend will help us along that path. So thank you so much for showing up, all of you. Thank you for participating. And if you want to chat, I'll leave the site open for a while. I need to go to my program and find out if I'm supposed to be somewhere else.
Thank you for the platform. Thank you for the platform, everybody.
Yeah, thank you.
Awesome stuff. Thank you, guys.
Thank you.
You'll be the better
Thank you,
doctor for
everyone.
it. Yes, thank you, Kate. Thank you.
Bye, everyone.
All right. Bye-bye.
Francis, I'll stop the recording and send it over to Dr. Cheney.
Thank you
Is
very
that-
much.
Or are
Thank
people
you.
going to stay on?
I don't
Or
think
Skype?
so. But
No,
William
okay.
has been there from the beginning, but we haven't heard from him. So
Okay.
I don't know if he wanted to say something.
Oh, he's gone now.
And Gina, yeah, Gina's there. Does anybody else want to chip in before we go?
No, I was just here just to see if you guys needed any help with anything.
Yes, yes, I know you were, Maya. I was felt much more secure when you were there, trust me. But Courtney's been looking after me too, so. Maybe Gina went. I had to keep getting up and letting the dog in and out if you wondered why I kept disappearing. Okay, I guess I should look at my.
I'll stop the recording then now, and
Right.
I'll end the session.
And I'll leave too. So
Okay, thank you.
See you elsewhere. Thank you.
Yes.